Welcome to the Deep Dive. Today we're getting practical about lactation. It's this huge commitment, physically and emotionally, and, well, challenges often come up.
That's right. Think of this deep dive as sort of a shortcut through the professional handbook. We're pulling from evidence-based protocols that guide how conditions are managed.
Our mission today is really to unpack that whole spectrum. We want you to walk away understanding how healthcare pros aim for informed, consistent, and importantly, individualized care.
Yep. We'll cover everything from, common physical stuff like soreness, all the way to more complex things like medications, exposures, and special care for vulnerable babies.
Okay, so we've broken it down. First, we'll hit those internal body challenges, the mechanics, soreness, supply issues, even mastitis.
Then we'll pivot to the outside world, meds, herbs, alcohol, drugs. How do those interact safely with breast milk?
And finally, special situations. Things like jaundice, which is common, and the very specific needs of preterm infants. Sound good?
Let's dive in.
Okay, so let's start right at the beginning. The latch. The source material says, what, over 90% experience some pain initially?
That's the number, yeah. But here's the key takeaway. That initial discomfort is one thing. Persistent pain or severe pain. That's not normal.
And it's a huge reason people stop breastfeeding early, right? Second leading cause.
Sadly, yes. Which really highlights why prevention, getting that latch right from the start, is so critical.
Can you break down why a good latch helps? What's the mechanics there?
Sure. So, with a proper latch, the nipple gets drawn way back into the baby's mouth, kind of near where the hard roof meets the soft part, the palate junction.
Okay.
That position protects it from the really strong pressure of the baby's tongue. When pain does happen, management is mostly about healing.
Like what?
Simple things, often. Air drying the nipples. Maybe rubbing on a bit of express milk or an all-purpose ointment, but definitely not petroleum-based ones.
Right. And avoiding things that might irritate, like harsh soaps or those plastic-backed nursing pads.
Exactly. Anything that traps moisture or causes friction is generally a bad idea.
Okay, so latch is secure. Next up is flow.
Right.
Let's talk extremes, maybe starting with letdown failure. You said that's rare.
It is pretty rare, yeah. And often it's tied to stress or anxiety. Basically, stress blocks oxytocin, the hormone that makes the milk eject or let down.
Ah, the psychological link. So management is about relaxing.
Pretty much. Things like soothing music, a calm environment, maybe partner support. Sometimes a warm compress helps. In really persistent cases, a doctor might prescribe a synthetic oxytocin nasal spray short term.
Got it. What about the opposite, the fire hose effect? Hyperactive letdown.
Right, much more common actually. The milk just streams out too fast. Baby can't keep up. You see choking, gulping, lots of air getting swallowed.
Leading to gas and pain later.
Exactly. So the management is about controlling that initial rush. You might need to gently break the latch right when letdown starts. Let the fastest flow spurt out onto a cloth and then relatch.
Or express a little first.
Yeah, expressing just a small amount, maybe 5 or 10 milliliters, can work wonders. It softens the breast, makes latching easier, and helps the baby get to the richer, higher-fat hind milk a bit sooner.
Okay, that actually connects neatly to the next point. Hyperlactation. Chronic overproduction.
It does. Signs of the mother might be things like constantly getting plugged ducts, milk blisters, maybe even mastitis, and leaking a lot.
And for the baby, you mentioned specific signs earlier.
Right. In the baby, you often see lots of gas, fussiness, and maybe those distinctive green, frothy, sometimes explosive stools.
Wait, okay, that's fascinating, because a mom might see that stool and immediately think allergy, maybe cut out dairy or something.
That's such a common misinterpretation.
But it's really just about the milk flow. How does that work?
It's a foremilk, hindmilk imbalance.
Yeah.
Foremilk comes first. It's higher in lactose, lower in fat. If the baby fills up quickly on mostly foremilk because the flow is so fast, all that lactose hits the gut at once.
Too much sugar, basically.
Yeah, sort of, yeah. It overwhelms the digestive system, causes rapid transit fermentation, hence the green, frothy, acidic stool. It's not usually an allergy.
So managing overproduction isn't about emptying the breast more. It seems counterintuitive.
It is counterintuitive. You actually want to reduce production slightly. Often the advice is to nurse on only one breast per feeding session. Let the other one stay full to send the signal, hey, slow down production.
Or use cold compresses. I saw cabbage leaves mentioned too.
Yep, cold compresses between feeds or chilled cabbage leaves tucked into the bra sounds odd, I know, but they can really help reduce swelling and signal the breast to make less milk.
Okay, moving from chronic oversupply to acute fullness, engorgement, that painful swelling around day 3 to 5.
Right, when the milk really comes in, It can make the breast incredibly hard and painful, and the areola gets so taut the baby can't latch properly.
So what's the fix?
Aggressive milk removal is key. Frequent nursing, like every couple of hours. If the breast is too hard to latch, express just enough milk to soften it before trying to feed.
Warm compresses beforehand, cold afterwards.
Exactly. Warmth before helps milk flow. Cold after helps with pain and swelling.
And if milk isn't removed effectively, that leads us towards plugged ducts and potentially mastitis. Making that distinction is really important for treatment, isn't it?
Absolutely crucial. A plugged duct feels like a specific painful lump or knot in the breast. But, and this is key, there's usually no fever.
Treatment is more physical then.
Right. Gentle massage towards the nipple, warm compresses before feeding, making sure the breast gets fully emptied, maybe changing nursing positions. For people who get them repeatedly, sometimes lecithin supplements help. It acts as an emulsifier.
Okay, then what signals mastitis?
Mastitis is inflammation. Sometimes it's a bacterial infection. The big differentiators are systemic symptoms, feeling flu-like, achy, run down, and importantly, having a fever, usually over 101 Fahrenheit or 38.4 Celsius.
And the absolute number one thing to do for mastitis is?
Keep nursing. Keep emptying that breast. It sounds like the last thing you'd want to do when it hurts, but it is the most important step.
Stopping suddenly makes it worse.
Much worse. Abrupt weaning with mastitis significantly increases the risk of developing a breast abscess, which is a serious complication. If it's bacterial, antibiotics will be needed, but milk removal remains priority one.
All right, let's shift gears. We've talked internal body stuff. Now let's look outside external exposures, starting with maternal medications. This must be a huge area of concern for people.
It really is. But the core principle we see in the guidelines is actually quite reassuring.
Which is?
That stopping breastfeeding just to take a medication is almost never necessary. There are usually safer alternatives available for the mother to take.
Okay, that's good to hear. So how do providers assess the risk?
They look at a few factors. How much of the drug actually gets into the milk, that's the milk-to-plasma ratio. They consider the overall potential dose the infant might get, the drug exposure index. And critically, they think about the baby's age and ability to metabolize that specific drug. A tiny preemie is different than a healthy 6-month-old.
So the goal isn't zero exposure, it's minimizing risk while maintaining breastfeeding.
Exactly. And there are practical strategies. For many drugs, taking the dose immediately after a nursing session is best.
Why then?
It maximizes the time until the next feed, allowing the drug concentration in the mother's blood, and therefore her milk, to pass its peak. Also, avoiding long-acting formulations is generally advised.
The source mentioned a couple of specific examples impacting supply too. Combined birth control pills.
Right, those containing both estrogen and progesterone might reduce milk volume, especially started very early postpartum, before supply is well established. Progestin-only methods are usually preferred.
And Sudafed. Pseudoephedrine.
Yeah, that common decongestant. Studies show it can actually decrease 24-hour milk production by about 24%. That's a pretty significant drop for some people.
Wow. Okay, what about herbal remedies? Lots of people turn to those, especially things meant to increase supply. Galactogogues.
This is an area where we need real caution. Most herbal remedies, including galactogogues, haven't been rigorously studied for safety or effectiveness during lactation. They aren't regulated by the FDA like drugs are.
So treat them like drugs.
Essentially, yes. Fenugreek is probably the most common one people try. Anecdotally, some report seeing an increase in supply within a day or two.
But there are side effects.
There can be. For the mother, things like diarrhea. A distinct sort of maple syrup smell in sweat and urine is common. And there's a potential allergy risk for the baby if there's a family history of sensitivity to legumes like peanuts, since fenugreek is in that family.
And some herbs are definite no-goes.
Absolutely. Anything that's a strong stimulant, cytotoxic, or a potent laxative should be avoided. Always best to discuss with a knowledgeable healthcare provider.
Okay, let's talk substances people might use recreationally or habitually. Alcohol first. There's that old myth, right? That beer helps milk production.
Total myth. Alcohol does the opposite. It actually blunts the milk ejection reflex by interfering with oxytocin release.
And how does it get into the milk?
The concentration in breast milk mirrors the concentration in the mother's blood plasma. Pretty much exactly. It peaks about 30 to 60 minutes after having a drink, a bit longer if taken with food.
Which leads to the pump and jump question. Does it actually clear alcohol faster?
No, it doesn't. That's another pervasive myth. Alcohol leaves the milk only as it leaves the mother's bloodstream, as her liver metabolizes it. Pumping removes the milk that's there. But the milk produced right after will still contain alcohol if it's still in her system.
So it's about time, not pumping.
Exactly. The general guideline is to wait about 2 to 3 hours per standard drink before nursing again. For example, for a 120-pound woman, occasional light alcohol use is generally considered compatible, but heavy or frequent drinking is definitely not advised.
What about smoking? Nicotine. This one had a surprising finding.
It really does. Obviously, smoking is harmful, period. But the evidence suggests it's actually worse for the baby if the mother smokes and uses formula compared to smoking and breastfeeding.
How can that be?
It comes down to the incredibly powerful protective benefits of breast milk itself, especially against things like SIDs and severe respiratory infections, which smokers' babies are at higher risk for. Breast milk offers a layer of defense, even in that context.
But the nicotine itself still gets into the milk.
Oh, yes. And at levels higher than in the mother's blood, about 1.5 to 3 times higher.
So the advice is harm reduction?
Precisely.
Yeah.
Quitting is ideal, of course. But if the mother continues to smoke, the advice is to smoke as little as possible, and always smoke after nursing, not before. Waiting at least 30 minutes, ideally longer, after smoking before feeding is recommended. Nicotine's half-life in milk is around 95 minutes.
And e-cigarettes aren't a safe alternative.
Definitely not. They contain nicotine, plus a whole host of other unregulated, potentially harmful chemicals and heavy metals. Not safe for mom or baby.
Okay. Marijuana. THC.
THC is highly lipophilic. That means it loves fat. And breast milk is high in fat.
So it concentrates there?
Massively. About 8 times higher concentration in milk compared to the mother's plasma. Studies have linked this exposure to potential negative effects on the infant's motor development.
And the official stance.
The American Academy of Pediatrics classifies THC, marijuana use, as contraindicated during breastfeeding. It's considered a drug of abuse in this context.
Finally, in this section, what about general environmental pollutants? Things like POPs or PFAS that we hear about. They show up in milk, right?
Low levels do, yes. It's unavoidable in our modern world. But the global consensus, led by the World Health Organization, is really strong on this point.
Which is?
That the overwhelming proven benefits of breastfeeding far outweigh the theoretical risks associated with these low-level environmental contaminants.
So the advice isn't to stop breastfeeding.
Definitely not.
Right.
It's about reducing ongoing exposure where possible through diet. Things like eating a varied diet, maybe trimming excess fat from meats, washing fruits and vegetables well, avoiding fish known to be high in mercury. Sensible precautions, not avoidance of breastfeeding.
Okay, let's pivot now to the baby's health, specifically starting with a really common issue. Neonatal jaundice, that yellowing of the skin. The sources say it's actually increased.
It has, yeah. It's partly linked to shorter hospital stays after birth, meaning jaundice might develop after the baby goes home, and also just higher rates of breastfeeding initiation, which sometimes has early challenges.
Right, so what causes jaundice physiologically?
It's caused by a buildup of bilirubin. Bilirubin is a yellow pigment, a breakdown product of old red blood cells, specifically the fetal hemoglobin the baby doesn't need after birth.
And babies make a lot of it.
They do, about double the adult rate. Plus, their liver is still immature, so it's not great at processing and clearing the bilirubin yet. If levels get too high and it's untreated, it can lead to a serious condition called kernicterus.
Which is brain damage.
Permanent neurological damage, yes. It's rare, but devastating. That's why monitoring is so important.
The sources break down 2 main types related to breastfeeding. Let's start with the early one.
Right. That's often called breast non-feeding jaundice, or sometimes lack of breastfeeding jaundice. It typically shows up early, days 2 to 5.
And the cause is not enough milk.
Exactly. It's essentially caused by insufficient milk intake, leading to dehydration and delayed stooling. Think of it as starvation jaundice.
So management is all about fixing the feeding.
Precisely. The key is frequent, effective nursing, aiming for at least 8 to 12 feeds every 24 hours. This helps hydrate the baby and, crucially, helps them pass meconium, those early dark stools.
Why is pooping so important for jaundice?
Because meconium is loaded with bilirubin, something like 450 milligrams. Getting that out of the baby system quickly is a major way to lower bilirubin levels.
Okay, then there's the second type, later onset.
Yes, that's breast milk jaundice syndrome. This usually peaks later, maybe around day 7 to 10 or even last a few weeks. It's generally considered a prolonged phase of normal physiological jaundice. The exact cause isn't fully understood. Might be something in the milk itself that affects bilirubin processing, but it's usually benign.
And importantly, the advice is not to routinely give water or sugar water to jaundiced babies.
Absolutely critical point. The AAP strongly advises against giving water or dextrose water. that doesn't help the jaundice, can interfere with gut health, and most importantly, it can sabotage breastfeeding establishment by filling the baby up with non-nutritive fluid. Frequent nursing is the answer for the early type.
Okay. Moving on to infants born a bit early, late preterm, 34 to 37 weeks. They look like term babies sometimes, but they face unique challenges, right?
Huge challenges. They're at much higher risk for hospital readmission. They often lack the stamina for effective feeding. Their suck-swallow-breathe coordination might be immature, and they have lower reserves of fat and glycogen.
The source called it a cascade.
Yeah, the late preterm breastfeeding cascade. Basically, the ineffective feeding leads to low milk transfer, which leads to low maternal supply, which can cause weight loss, hypoglycemia, jaundice, and dehydration in the baby. It's a vicious cycle.
So intervention is key. Pumping.
Often, yes. If the baby isn't effectively draining the breast, the mother usually needs to pump frequently, like every 3 hours around the clock, to build and maintain her milk supply while the baby gets stronger.
And for these babies, and even more premature infants, human milk is especially beneficial.
The benefits are arguably most pronounced for preemies. We see significantly lower rates of devastating conditions like necrotizing enterocolitis, NEC, and sepsis. Also, better long-term outcomes like improved vision and potentially higher IQ scores later.
But their nutritional needs are higher too.
Extremely high. Interestingly, the milk produced by mothers who deliver prematurely is naturally higher in protein and calories initially. But even so, it's usually not enough on its own. Fortification, adding extra protein, calories, vitamins, minerals to the mother's milk is standard practice in the NICU to meet those high growth demands.
Okay, one last infant topic, allergies and intolerances. Breastfeeding helps prevent allergies.
Yes, exclusive breastfeeding for at least the first 4 to 6 months is strongly associated with protection against developing allergic diseases like eczema and asthma.
But sometimes issues still arise. Important distinction. Allergy versus intolerance.
Right. A true allergy is an immune system response, often involving IgE antibodies, typically to a protein like cow's milk protein passing through the mother's milk. And intolerance is more about digestive upset, maybe causing symptoms like colic or gas, but without that specific immune reaction.
And let's bust that myth. Mom eating broccoli or beans, does that give the baby gas?
Nope. That's a classic one. The gas-producing components of those foods, the fiber, aren't absorbed into the mother's bloodstream, so they can't get into the milk. Gas in the baby is usually from swallowing air or, as we discussed, maybe that fore-milk-hind milk imbalance.
But sometimes if a baby is really fussy or colicky, eliminating common allergens from the mom's diet can help.
It can, particularly eliminating cow's milk protein. Sometimes eggs, soy, nuts too. If there's a suspected allergy or severe intolerance, working with a healthcare provider or lactation consultant on a structured elimination diet is the way to go.
All right, let's wrap up with some logistics and support. First, are there times when breastfeeding is absolutely not recommended? Medical contraindications.
There are very few, actually. For the baby, the main one is a rare metabolic disorder called galactosemia, where they absolutely cannot process the lactose in any milk, including human milk.
And for the mother.
In developed countries, where safe alternatives like formula are readily available, contraindications include the mother having HIV, untreated active tuberculosis, undergoing certain types of chemotherapy, or being dependent on illicit drugs.
Okay. For mothers who are pumping, what are the basic storage rules? How long is milk good for?
The general guidelines are pretty generous. Freshly expressed milk can sit at room temperature for up to about 8 hours.
8 hours, wow.
Yeah. In the refrigerator, it's good for 4 to 7 days. And in a standard freezer compartment, maybe 6 months. But in a deep freezer, it can last up to 12 months. Always label with the date.
Good tip. And for establishing supply, especially if separated from the baby, what's the pumping goal early on?
The key is frequent stimulation early. Ideally, starting pumping within about 6 hours of birth if needed, and aiming for 8 to 10 pumping sessions every 24 hours. That frequency is crucial to mimic a baby's feeding pattern and establish a full milk supply, which is typically around 25 to 35 ounces, or 750 1,000 millivowels per day.
And what if a mother's own milk isn't available, especially for those vulnerable preemies we talked about?
That's where human milk banking comes in. Organizations like HMBANA, the Human Milk Banking Association of North America, collect milk from screened volunteer donors.
Screened is the key word there.
Absolutely. Donor mothers go through health screening similar to blood donors. The donated milk is then pasteurized to kill bacteria and viruses and tested before being dispensed, primarily to fragile, hospitalized infants whose mothers cannot provide their own milk.
So informal milk sharing, like finding someone online, that's risky.
Very risky. The sources strongly caution against unregulated stranger-to-stranger milk sharing. You have no idea about the donor's health, medications, drug use, or how the milk was handled. Risk of bacterial contamination is high. Pasteurized donor milk from a milk bank is the safe alternative.
It really highlights the importance of support systems. The source mentioned a specific program.
Yeah, the Rush Mothers Milk Club, a program for mothers of NICU infants. They achieved incredibly high rates, like 95 to 97% of mothers providing their own milk.
How? What was the key?
It seemed to be a combination of really clear, consistent messaging from the entire staff about the critical importance of the mother's own milk, OMM, and providing immediate, easy access to hospital-grade pumps and support right at the baby's bedside, making it the default expected path.
That really underscores how much environment and support matter. Hashtag tag tag outro.
It really does. So we've covered a lot today, from the nitty-gritty of sore nipples and mastitis through navigating medications and substances safely to understanding jaundice and the special needs of preemies.
Yeah, the whole landscape. And I think if there's one underlying message that came through strongly, it's that fundamental point about risk versus benefit.
Right. The data consistently show that the profound, multifaceted advantages of human milk generally outweigh the potential risks from, minor exposures or challenges.
Which really makes you think about all the benefits we can't easily measure or list on a nutrition label, the immune factors, the bonding, the long-term developmental boosts.
Exactly. And it leads to a final thought, maybe something provocative for you to consider. If we know the benefits are so vast and that informed support is key, what could we achieve if we really committed systemically to prioritizing that kind of comprehensive maternal support like that RUSH program showed, rather than defaulting to unnecessary restrictions or hurdles?
How much higher could we raise that bar for both infant and maternal health outcomes, not just here, but globally?
Something to think about.
Indeed.
Yeah.
A lot to process. Thank you for trusting the Deep Dive team with your learning today.